The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome to all of my dental colleagues who are interested in solving the problem of TMD. I am Tony Urbanic, and we're here for the next episode of TMD Demystified. I welcome your interest in what I have to say, and today I think we'll cover a very interesting part of what I've learned and what we do to solve the TMD mystery, and that is the protocol that goes along with the use of the device. We will cover that in just a little bit, but something occurred in my own practice yesterday that I wanted to share with you that I think drives a point home that's very important, and it kind of goes along with how all this was, quote, discovered. As you've heard me say before, I don't think I discovered anything. What I did was arrange a lot of information, connected the dots that directed the solution to the right area, and then investigated that area and found that, yeah, that's really what's going on. My initial story, which I'm going to briefly again go over, which I've voiced a couple times already on previous episodes, and that is I tried to solve the problem, just trying to solve what I considered an unsolvable problem. No one else had a solution, surgical or non-surgical, and I took it upon myself to see if I could figure it out. And the first step of that was to actually sit down and actually talk to the source being the patients, and ask them everything that I could determine was of value from what their history was and what they had to say about it. And inevitably, out of the first 24 patients, literally half of them had to say the same thing, and which was, if I take my finger, a pencil eraser, my tongue, a piece of cloth, and gently put it between my front teeth and bite down, it feels better. And that was the key that led me to make a device that separated the posterior teeth and allowed for posterior disocclusion, which brought us to this point right now. So that's how it all started. That was 10 years ago. And yesterday, I had a patient come into the office, typical woman, middle-aged, and we started, as I usually do, asking her about her symptoms, and tell me all about it. Whatever you have to say, I want to know what you have to say about it, not necessarily what others have to say, tell you about it. And she gave me her symptoms, and I noticed as she was talking, she had around her neck a string, and at the bottom of the string looked like it was a turquoise or blue piece of rubber. It was in the shape of a leaf, like a tree leaf, small tree leaf, and it was hanging around her neck. You know, a lot of women bring in jewelry, and they bring in, you know, crosses and things around their neck. And this woman had a rubber thing hanging at the bottom of the string, and I didn't pay much attention to it. I didn't bring it to her attention that I was looking at it. And as she began to tell me her story, she said, "Oh, by the way," she says, "this thing I put in my mouth and it makes it feel better." And I broke into a laugh, and I thought I'd just share that picture with you this morning. After we finished the consult and she went ahead and proceeded with impressions and things, I said, I have to get a picture, because 10 years ago, I never took a picture of any of these women as they described what they were going to put between their teeth. And this lady did. And let me see if I can pull up this picture for you. There we go. So very nice woman who agreed to take a picture. She says, no problem. I said, I'm just going to show it to my colleagues to make a point. And she said, no problem. Of course, I had her sign a release. So just, we're all HIPAA compliant here. And she said, no, I'll be happy to show you, other doctors what I found that is helpful. This is what I found 10 years ago. This is where it all started. And I had to figure out, well, why putting something between your front teeth? Why does that make a difference? How much difference does it make? How long do you have to keep it from between your front teeth? Now, one other point about this, in my earlier part of treating patients and using this, I had more time than I do now. I have a very concise consultation that I usually go through, but back then I had more time to sit down with a patient. And I remember many years ago having enough time to actually tell the patient how I came up with this, how it all started. I believe she asked me, she said, well, where did this come from? I mean, and I told her the story that if the patients told me that if they take their finger or their tongue or a piece of cloth or a pencil eraser and gently put it between their front teeth, it feels better. But I also said that you have to keep it there long enough. And I said, we found that basically the standard protocol is that you need to keep your teeth separated in the back at the beginning for a minimum of 2 months. And she looked at me and she said, do you mean that if I can hold a pencil between my front teeth, it will make my symptoms go away? And I said, yes, ma'am. If you can hold a pencil between your front teeth for 2 months straight, I said, yeah, your symptoms are going to go away. She kind of glared at me. I don't know whether she believed me or whether she thought I was being a smart butt, but, and I actually don't remember whether she went through and got a device or not. But I remember that very well because I remember the look she gave me when I said, yes, ma'am, you can figure out a way to hold a pencil between your front teeth long enough, your symptoms are going to go away. So I wanted to share that story with you, which actually it happened yesterday in my office with this patient. And I think it's very meaningful, timely, and makes the point, and a good segue to go into the protocol itself. So the device, as I've discussed, and how it works and why it works, isn't anywhere near as effective unless you use a proper protocol to use it. And we've standardized that protocol, which I'm going to discuss here. The reasons for a protocol, in other words, we can talk about what the protocol is, and then we also need to talk about, well, why do you need a protocol? Which brings to mind a little story. I like to share these stories with you, I guess. But this one comes from many years ago in my work in Haiti. And my first time down in Haiti, I flew down with a generator, a small generator in the back of the airplane. And I remember the morning we were setting up the generator, back of the little hut, the little place where I was working, one of the Haitian men helped me carry it because it was about 120 pounds to the back. And I brought up my little toolbox that I brought down with you. Keep in mind, we're out in the middle of nowhere. We're at 75 miles. We're 75 miles from the closest town of any size, all in an area where there are nothing but thatched roofs and dirt floors, 12 by 12 huts. And my place where I was working had a tin roof. It was upstat for the town, and they had prepared a place for the new doctor, and they had a tin roof. And out back we put the generator because it was going to make a lot of noise. And as I was setting up the generator, I opened my toolbox, and the fella who helped me carry the generator to the back, he looked in the toolbox and he grabbed a hammer, and he held the hammer in his hand. And he looked at me in all sincerity and he went, technology. Of course, I didn't speak Creole. He didn't speak English, but he wanted to communicate with me that I was using technology and holding this hammer. And he was very proud that he could hold this hammer representing technology in his hand. Now, I thought at the time that that story would carry me forward, and it did for many years. I've quoted under many circumstances, it told many circumstances. But, if you have a tool, but you don't know how to use it, this was the first time this gentleman had ever held a hammer in his hand. Now, obviously, he kind of knew how to hold a hammer, but if he had pulled out, say, a vice grip out of that toolbox, which is a little complicated, it's kind of like a plier with a screw on it, he probably wouldn't know how to use that correctly. And it just proves the point that if you have a tool but don't know how to use it, the tool is not going to be effective. Or the one I use frequently with patients is, this device that we use here, it's a tool. But if you don't use it correctly, it's not going to be as effective. And then I use the example, if you have a screwdriver, but don't know which end to hold the screwdriver on, you're not going to be able to drive the screw into whatever you're using it for. So it's a very basic point. And the point is the device itself, patented, FDA approved, is nothing more than a tool to be used correctly. And that's what the protocol is all about. And if you use it correctly, it will be much more effective. That doesn't mean that if you just slap it in somebody's mouth, it won't give you some assistance, but you never know how the patients are going to use it. And we'll talk about that when it comes to patient compliance. So, as I said, the protocol is important. It's important to discuss, why it's important to have the protocol and important to use the protocol, and then what is the protocol that we find works best. So first of all, it took me a little time to determine that the best time frame to keep the patient into 24-hour per day using the device, disoccluding the posterior teeth, was for 2 months. Now, over the past 10 years, I have seen many patients come back in 3 weeks, and a huge percent of their symptoms are diminished. I had a patient within the past 2 days, whether it was yesterday or the day before, came in at 3 weeks, and she said 100% of my symptoms were gone. And she had majority of her symptoms on the list: headache, earache, jaw pain, neck pain, tinnitus, etc. She had 8 or 10 of the symptoms, and she said, they're all gone. I was awesome. But that is not the way it is with everyone. And so the protocol is a standardized protocol, which allows us to work best for the majority of patients that come in. And even in that case, I can tell you that just because the patient came in 3 weeks does not mean she was fixed. You have to make sure that they're stable and that they don't regress easily. And what I found was that the first part of the protocol is 24/7, except when you eat, for 2 months. And that gives you the largest decrease in inflammation. It's all about decreasing the inflammation in the joint. It's all about decreasing the inflammation, no matter where the disc is, no matter how it's dislocated, no matter whether they're locked closed. It's all of it is irrelevant. It's irrelevant what the x-ray looks like. It's irrelevant how much degeneration you see on the joint, in the joint on the x-rays. And when I say x-rays, I just mean Panorex. We do not find a need to get MRIs or CT scans. It's irrelevant. You'll see if you have significant degeneration of the condylar head, you'll see it on a Panorex. You can note it in the chart, but it's irrelevant about whether or not the inflammation is going to decrease or not. So that the first 2 months are critical in giving the joint itself enough time to take the damaging loads off the joint, decrease the inflammation, and is part of the standard protocol. The other reason for the protocol is for patient compliance, because as you know, as a practitioner, whatever you do, it's a huge problem for us, and it's a huge factor in whether you get the proper result of whatever your treatment is, whether you're doing operative dentistry, or you're doing oral surgery, or you're doing orthodontics, or you're doing periodontal treatment. Always there's aspects that you're asking the patient to comply with a certain protocol to give them the best benefit of whatever you've done. That really applies to TMD treatment, what we figured out here and what we use, because patients who follow the protocol do better. You can't just slap it in somebody's mouth and expect the patient to determine what the proper protocol is. Now, I can tell you with great experience, and patients, for the most part, they just want to wear it at night. And even then, they don't want to wear it all the time. From the patient's point of view, they want to put it in their mouth until the symptoms go away, and then take it out of their mouth and put it in the drawer. And I've seen that many, many times. That is why we stress and educate the patient on the proper protocol to use, and stress why it's so important. And I find when we do that, the patient is much more compliant when you outline the protocol to begin with. And this is what is expected of you. This is the protocol. This is where you'll get the best effect of this tool that we're going to use and you're going to use on a routine basis. And of course, there are patients who do not follow the protocol, and they do what they want to do. And sure enough, you can see over a period of time, they will come back and they will not have the same experience that the patient who follows the protocol will have. It's common sense, but you see it all the time. Don't get mad at the patient. It doesn't help. They know that they're not doing what they're supposed to do, and you just go with the flow and reinforce that the protocol is what works best, and the protocol is there for you to use so that you get the best result. Protocol is also important that you document. You can document with the protocol. When you have a standardized protocol, it's much easier to document what's going on. As I've described many times in prior episodes, the standard key question every time a patient returns to the office, whether at any point in the protocol or any point when they come back to see us, let's just say, they've been, you've discharged them, you haven't seen them for 3 years, and they're back in the office, and they're having some symptoms. Well, are you using your device? When was the last time you used the device? Are you using it according to the protocol? So all of those things, it's important to have a protocol so that you can determine and put in your chart, your record, what part of the protocol they're in, and whether or not they're actually doing the protocol as requested. And that's extremely important. And document. And it's easy, and it doesn't take but a few characters on the computer. We're not talking about paragraphs. We're talking about a few words and a few numbers. And then the protocol is also important to have something as a standard protocol to judge when someone is not coming back with the usual and customary results, because we know what those results are. In fact, both on initial white paper that I did many, many years ago, and most recently on the independent study that was funded through Middle Tennessee State University based on our 3,000 cases. And using this protocol, the patients will return at 3 weeks after delivery of the device, using it 24/7, and their average response to the key question, which is take all of your original symptoms, lump them together in your mind, average them all out, and tell me what percentage of those symptoms are diminished or decreased. Sometimes you have to repeat that a few times because everyone wants to say how much better they are. You do not want to know how much better they are because that is not as good as objective question. The best objective question is how much or what percentage of your symptoms are gone or diminished. That is a better objective number. And that is the question that is asked day in and day out around here, both myself and my associate who treat these patients. And the average response at 3 weeks, 24/7, is 70% of the symptoms, whatever those symptoms are on that long symptom list. At 2 months, the average is 86%. At 4 months, it is 90, it's either 94 or 96%. And at 6 months, and we hardly ever get anybody out to 6 months because long before then they're fixed. And no matter how many times I say, well, I just want to check in, make sure you're stable, that is rarely do they come back at 6 months, which is okay. I just want to make sure they're well and that they're happy. Well, 70% at 3 weeks, 86% at 2 months, and then in the 90s by the time they're out 4 months. Pretty impressive numbers. We have the numbers. If you find that unbelievable, come on down. Check our records, check our patients. We can document this. So again, I say that I encourage you to look into this because there is a lot of treatment out there that is nowhere near as successful. In fact, sometimes very damaging, besides not having any success at all. So the protocol allows us to then adjust, the point being, protocol allows us to judge what we're doing if we're not getting the usual and customary response. Now, when I say 70% average, it's an average. Some people come back and say 30%. Some people come back and say 100%. Some people come back and say lower numbers. Now, I'm going to make a comment on that because no one has asked yet. There has been a comment, but the question would be, the question I would ask if I was looking at these podcasts and following it along, different episodes. One question I would say is, what do you do when someone comes in and they do not have a good response or they have no response? That happens. Not very frequently, but it happens. Years ago, within the first couple of years, certainly within the first couple of years, going along pocket, and people are coming back and they're giving me these numbers and they're happy and the response is good and follow them through and the symptoms stay away as long as they follow the protocol. And patient comes in at 3 weeks and say, take all your symptoms, lump them together, average it out, what percentage of symptoms are gone? And the patient says none. And I go, whoa. I look in the mouth, device is in the mouth, separation is appropriate, 1.5 mm to 2 millimeters posterior and centric and eccentric. And I looked at the patient and said, have you been using this 24/7? Oh, yes, sir. I promise you, I've been using just like you said. And I said, you're not getting any difference in the pain? Because of course, tinnitus, subjective hearing problems and vertigo go slowly. So I don't expect that to go down necessarily in 3 weeks, although I've seen it. But the painful symptoms, absolutely, on the average case, 70% at 3 weeks, 24/7. But this patient is none. And I go, all right, so you've been wearing it 24/7? Yes, sir, I've been wearing it. So that gets into a whole other discussion. It's going to get in a whole other episode, but I'm going to, without teasing you about what it is, it's all about the vertical dimension of the lower face, basically the position of the lower jaw and the vertical jaw, and how much force that can be placed on these joints under certain circumstances when the vertical dimension is short. And again, I don't want to get into this in this episode because it's not lengthy, it's quite simple. We'll talk about what I used, how I discovered it, what it came from. But at that point, again, without holding you in suspense, you add acrylic to the anterior pad, not much, don't have to be much, millimeter, increase the vertical dimension a little bit, and it takes more load off the joint, and patient will come back again in 3 weeks or 6 weeks, and they'll say, yeah, 50% of my symptoms are gone, or 70% of my symptoms are gone. But the point of this discussion is that allows us, a standard protocol allows us to take the patient through the protocol and know when the patient is not getting the result that we expect, at which point you know you need to do something. You just don't say, well, I don't know, or you don't go, well, just keep going. There is a reason for everything. There is a reason for everything, cause and effect. And if you can ferret out the cause, then you can change the effect. Or the opposite, if you have an effect, then you need to be looking for the cause. In this case, vertical dimension. It doesn't happen very often. I would say less than 10% of the cases have that issue that needs to be addressed. All right, so the protocol is important to be able to adjust the device, know when to adjust the device, because it's outside the standard protocol and in the standard expectations. So what is the actual protocol? The actual protocol is very simple. We worked it out over several years, and that is, after delivery of the device, make sure it fits well, obviously, make sure that you have bilateral function of the anterior maxillary teeth, mandibular teeth against the maxillary device. So it has function evenly on both right and left sides. And you bring the patient back at 3 weeks, and then you bring the patient back 6 weeks later at 9 weeks. That is 9 weeks equal 2 months, and for that first 2 months, they are 24/7. I always invite the patient to come back early if the device for any reason is not comfortable, tight or loose, or not comfortable, come on back. And that can be fixed easy, make it comfortable without any trouble. And then you follow them along with those numbers at each individual patient contact. Note in the chart what percentage of their symptoms are diminished or gone. And then after at the 2-month point is usually when we pivot into nighttime only. Now, the definition of nighttime only is every night indefinitely, or better said, every time you go to sleep, because people who brux will brux when they sleep, not just at night. So nighttime only. And what we found over the past few years, about 15% of the patients also need to wear it more during the day, but never 24/7 again. I emphasize that, never, ever 24/7 again after the first 2 months, which prevents any kind of super eruption of posterior teeth in adults. And then those 15% that need to wear it more during the day figure out, in fact, they tell me they figure it out. I hear frequently from the ladies here in Middle Tennessee, I figure it out when I'm in traffic. I figure it out when I'm on a computer. I'll put this thing in my mouth, because that's when they're tense, that's when they're bruxing, that's when they're clenching. That in conjunction with wearing it nighttime only carries them through. So 85%, what we found is 85% nighttime only. That's all they have to do. And 15% find that they need to wear a little more during the day, and they usually figure out exactly when. I make sure that they fully understand they cannot wear it more than 6 or 8 hours per day extra. but they can go on forever, 6 or 8 hours a day, as long as they're out of it for 6 or 8 hours a day. You will not get supereruption of posterior teeth in adults. So that is the technical protocol that we use in conjunction using the tool, which we have found extremely effective in treating TMD. I think I've covered all the points I want to do today. I hope you found this interesting. I hope you found this something that you would like to do if you would like to get involved with our company, TMJ Services, and be licensed to use the Urbanic device and protocol for your patients. You can contact us directly through myself or Naomi, or you can go to our website, www.tmjservices.net, and sign up for the course. Those who are network providers using the device and the protocol have to take our course, which covers in detail all the things you need to know that I know in treating these patients successfully. And it's about a 12-hour, 10-hour course if you're consistent with it, and then use it in your practice. We're having a growing network of doctors who use it. I'm on the telephone or on the computer and emailing every day to our doctors who are finding it as successful as I. Honestly, no one is doing as many as we are in our practice. I mean, we are seeing between 80, on average, 80 to 90 new referrals per month from Middle Tennessee. But the other doctors throughout the country are now part of our network and taking the course and licensed to do it, are picking up their numbers because it's a huge problem. I've said before, I'm on a mission. Yes, I'm a CEO of the company. Yes, we're a for-profit company, but that is not my mission. I did not intend in any way, shape, or form to create a TMD company. But what I found, once I found the solution, and I saw so many patients, and I actually saw day to day how many lives have been ruined with these symptoms that were totally misunderstood, not understood, misdirected, misdiagnosed, treated with things that were not successful or damaging, and that the numbers are amazingly extreme. 45% of females have TMD symptoms, maybe not severe, many of them life-changing negatively, because I see it all the time. But if you know 10 females, I promise you, if you ask them that list, do you have some or all of these symptoms, 4 to 5 of them are going to say yes. Yes, I have those symptoms. And then you do this, and if it hurts, the joint's inflamed, and if it's joints inflamed, they have TMD. Inflammation of the temporomandibular joint is the definition of TMD, along with the symptoms. If they have the symptoms and they have inflamed joints, they have TMD. It is that simple. That is how you diagnose it. And then, as we discussed today, how you treat it with a tool that separates the back teeth, that is comfortable, that you can talk on, that you can wear 24/7. Which brings me to one, I think I'm going to cover one more brief little thing about this, and that is, I've already seen here in Middle Tennessee, some of my colleagues, because I'm well known as the jaw doctor, the TMD doctor here in Middle Tennessee by far. And some of my dental colleagues have figured out that they can make their own devices. Well, that's fine. If you want to take a suck down, or you want to make a night guard and slap a big wad of plastic on the front of it to separate the back teeth and tell the patient that's treatment, that's fine. Of course, we don't want you violating our patent, and that can lead to significant problems with patent attorneys, and once that goes through civil court, then notifying the dental board. But the point I'm trying to make is, if you want to do that, some of my colleagues do that. And I see those, and the reason I know that is because those patients come in with one or two of those little things in their hand or in a brown paper bag, and they show me the Dr. So-and-so made them this and said that it separates the back teeth and it's going to solve the problem. Well, the problem with those is the patient cannot follow the protocol, which is 24/7 for the first 2 months. And even at nighttime, some of those things are not comfortable. There are other things that separate the posterior teeth, like the NTI. It's a great little device. The problem is you can't talk with it. You can't wear it 24/7. I'm not downgrading it. I'm just saying that you can't wear it 24/7. We found that the protocol is extremely important. So that's another reason to have the protocol, and that is we found that it works. That protocol works, and if you just block your front teeth open whenever you can or whenever you want, it definitely doesn't work as well. So that's what I have to say about the protocol. I look forward to comments. I look forward to questions. You can contact me or Naomi if you want to discuss becoming a network provider in the network. I encourage you to do that because I'm on a mission. There are literally, if you do the numbers, 45% times the population is 76 million females in the United States of America who suffer one or more of the TMD symptoms, and they want those symptoms to go away. Most of them don't even know what the symptoms are caused by, let alone how to get them to go away. And truly, we have the solution. And if you question that, come on down, visit us, look at our records, look at our study, which out now. So that's enough for today. I appreciate your bearing with me and my interest in trying to help others and to help my colleagues to use this for the betterment of your own practices. I'm Tony Urbanic, and I look forward to speaking with you at our next episode, which will occur on a weekly basis here on Dental Town. See you later.